trying to talk about the complications of cataract surgery and how do we vitreoretinal surgeons should manage, and this will also take into view the cataract surgeon there. There will be some discussion about that what can be done from their side and what a new young VR surgeons can do in these patients. So I will introduce my co-instructors. Dr. Diksha is assistant professor with us at PGI Chandigarh. She's a vitreoretinal surgeon, and Dr. Simar is a young resident registrar with us, and he's a budding VR surgeon. So we'll be starting with our course there. So I'll be giving a talk on the management of TASS and endophthalmitis there. So whenever you have done a nice any surgery there, so you are what you're worried about next day is that this kind of a news there in the papers. If you are not very lucky to get away with a single case, so this happens in our day-to-day practice, and what we can do to prevent it actually. So I have these. I'm fond of these mnemonics, and now I'm fond of these three E's here. And what, as a surgeon, as an ophthalmic surgeon, we should follow when we are going inside the eye with the blade. That we have to have early recognition of the whatever has happened to the eye, early treatment, and early referral in these patients. These three E's are very important. So whenever we are seeing a post-operative inflammation, what comes to our mind is, being a VR surgeon, we think everything is endophthalmitis. But cataract surgeon will say, no, it's probably TASS, or it's just increased inflammation. So he will not believe that it's endophthalmitis. Fair enough. So what should be done is we should be able to differentiate between these two entities on day one. Okay, so whether it's a toxic anterior segment inflammation or endophthalmitis or just a more than usual inflammation, so everybody should know their kind of what kind of handicap they have, what kind of surgery they have done, what sort of inflammation will be there on day one. So there is acute inflammation of the ocular courts except sclera, infection etiology, and that is acute sterile anterior segment inflammation, unidentified toxic insult. People have blamed so many things in these groups. So to prevent these episodes, what we have to do is we have to remember that early recognizing it. For early recognizing, I always teach that there are 4-5 things you must do to every patient, and you should document these things. Only then next day you will be able to see whether what has happened to my patient. You should note down the visual acuity and note it down. You should note down the IOP in these patients. You should write about the cornea and the section, whether you have formed a sclerotomy there, whether you have formed a SICS incision. You should be able to write that. How is it? If you write it's cornea normal, that means you have seen the cornea. If you nothing written there, anterior segment within normal, probably you have not seen the cornea. So always try to write, because next day you may not be there. Your colleague may be watching it in a practice where you are not alone. So it is important to note down cornea section. It is important to say anterior chamber there. So you do not write only cells and flare. You will write no hypopyon word there, because probably next day hypopyon is there and you have not written no hypopyon. Probably somebody will say maybe he has not seen the hypopyon there. Then you write the media clarity. You always put a 90-D lens. Any surgery, we should be able to see the disc there. We should always examine these patients in dilated, undilated pupil. This is very important. The visual acuity, I have already said, day one. I mean, all of us scared to do visual acuity in our patients, because you know that there's a corneal edema. Patient will say, I operated at 612, today is 618. Okay, but you should get it done. You should note it down with a pinhole that what is the vision today. Today is 618. So tomorrow it becomes 3/60. So your antenna should be up. So probably something has gone wrong, and I should look for the cause there. So same with the intraocular pressure. This will give you a clue that your wounds are not leaking. You're not, there is no inflammation there in these patients. You should always do a non-contact or a contact, whatever method you can do is in these patients. And a cornea section, as I've already said, always move the upper lid up, so see the cornea, how's the section, how are your sections, whether there is corneal infiltrates, anything. You should put down these patients, because if you have put down these things, only then next day you will know that everything is all right in these patients. So be it a GFS wound, be it a vitrectomy, sclerotomy, you should note down these findings, because such patients, if you don't pull the upper lid up, you won't be able to see the corneal infiltrate there. You will be seeing the inflammation all the time, but you are not seeing that there is a corneal pathology, because if the endophthalmitis, the corneal involved, the game is already lost there. So you have to pull the lids up. You have to, because nowadays we are not doing the with suture surgeries where you are not allowed to touch the lids. You can touch the lids and you can retract them and see what is happening in these patients, because if you miss such patients, ultimately they will have this kind of a picture. The whole cornea will be involved, and we will not be able to salvage this eye. Can I have the pointer, please? So anterior chamber again. Anterior chamber, I've already said, you're looking for cells there. You're looking for hypopion there, flare there. You have to tell that what kind of cells are there. Just writing cells is not enough. So you have to tell that I saw today 1 plus cells. 1 plus cells today is all right. Patient next day comes with the pain. Now he has 4 plus cells. So something has gone wrong. Either patient has not used the drops properly, either something has gone wrong. Probably you will ask the patient if he has not put the drops, you'll be fine. You said, okay, I'll change the drop, I'll increase the frequency, I'll see him after day after. Now 4 plus become 2 plus. It's a good sign. So always write what kind of cellular action is there, whether you are able to see the iris details. So that will be shown by the flare there. And again, I told you the hypopion, you have to pull the lower lid down, because the lower lid is always covering the some part of cornea there in many of the patients. But if you pull it down, only then you will be able to see 0.5 mm of hypopion. 1 millimeter hypopion is obvious, but the 0.5, 0.3 kind of hypopion, the streak hypopions are seen with once you pull it down. So that is important in these patients to see this. These are easy charts. You can put it in your clinics. Once you use it for 1 or 2 years, then you can cram it and then can remove from the clinic wall actually. Media clarity is again very easy. There is no rocket science in it. If you're seeing the disc and the vessels 1, 2, 3, 4, 5, that kind of a media clarity is there. Just seeing a red glow and yellow glow is not taken from the ophthalmologist, because we have to move a little ahead. This is the optometrist's job to see whether the red glow is there or not, because what we have to put a 90D or indirect on the head and tell it is more than the red glow there. Okay, so you have to tell that which kind of media clarity is there, because in every infectious disease, the media clarity will go down in this patient. So again, now you have known these steps. Now you are trying to see that patient. You have operated on day 1. So day 1 you have seen that patient. Now you see that day 1 there is lots of inflammation in the eye, and the good thing about TASS is it occurs on the day 1. If somebody says day 1 doctor patient was fine, 2 was fine, third day पे उसका TASS हो गया. I mean, there is no such entity like third day TASS. Third day it is endophthalmitis. Okay, so TASS occurs on the day 1. It has to occur on the day 1. It doesn't occur on day 3. So TASS occurs on the day 1, and there is no lid edema in these patients, and you see lid edema in endophthalmitis. Endophthalmitis can occur any time. It will occur, day after. It can occur after 6 weeks, and after 3 months. So you have to remember that cornea is cloudy by and large in the TASS. It can be cloudy, vary if the corneal involvement is there. But the sign is no lid edema, more pain. The patient will call you in the evening from home. I am having lots of pain. So this is the patient, probably the TASS is very likely. You call the patient up and see what is happening there in this patient. So you have poor iris detail. I've told you that cornea is cloudy, IOP is high. You will not be able to see anything there. And the pupil will not be just fixed and small. It will be little 6 millimeter and kind of a fixed kind of a pupil there. That is the feature of a TASS there. Media clarity is no view, but the moment you put your ultrasound there, you will not see anything in the vitreous cavity. Again, you have a TASS there. You can easily say that you can have TASS there, but there I said lid edema, kind of pain, matting of lids, all these things will be there, and you will see lots of exudates in these patients. So now, if you have made a diagnosis of TASS, what you will do as a cataract surgeon, you will now introspect, you will think about it. What was done in the OT, what new was done, whether anything was new, my assistant was new, I used some viscoelastic for the first time, and thorough checkup you will do, and then you will see whether my surgery was prolonged, whether the PC was ruptured, and you will see that what is the cause for this TASS or increased inflammation in these patients. And if you don't find anything else, then what you do about TASS. So TASS is, if you say if the patient is a TASS patient, you know what to do. This is what we commonly teach and what we follow in because we are as a referral practice. High volume cataract surgery is done by Dr. Jagatram. He operates more than 100 cataract surgeries are done in PJMR daily. So we get these kind of things. So if you have a TASS there, the patient will be brought to the cornea and they will refer to us VR. So there also they know that you start frequent topical steroids in these patients and manage the IOP in these patients. When I say frequent topical steroids, I mean is every 1 minute for 5 minutes, every 5 minutes for 30 minutes, and every 30 minutes. And then manage IOP, and you will see this patient before you get up. Like the court, the judge sahab gets up at 5 o'clock. Before you get up from your chair, you will examine this patient. Patient comes from far off, keep him under daycare. Comes from home, send him home, call him at 5 o'clock. So now you will assess that patient at 5 o'clock before finishing your clinic. So you have two scenarios there. Improvement is present, improvement is not present. Okay. If the improvement is present, good, fair enough. Continue same treatment, half hourly, see next day morning, and sleep a peaceful sleep. Okay. And if there is no improvement, now you do a vitreous this exudates kind of thing. The exudates will come now. Okay. This is the task. It will improve with every half an hour, every 15 minutes drops. You will see the fibrin will shrink. You will see the IOP will come down. It has to. If the patient has religiously put, nearly 20 times of, topical steroids, he will be better. But if you don't see it and exudates are present, now it is the time. Then you should talk to your VR colleague or you are a VR surgeon yourself that now it is the time to tap and inject. Let's don't delay this patient too much. So there and then in the evening you can tap the patient and inject with intravitreal and call him in the morning, or you can refer. He's like a hot potato. Don't keep hot potatoes with you. Share it with a VR surgeon. Always have a VR surgeon colleague as your friend there. So if there is an endophthalmitis there, this is what we do still do in the vitreoretinal surgeons do. We follow endophthalmitis vitrectomy study, though done in the West, but still we follow some of its things because they are good, but we don't follow it blindly. I'll tell you why. So endophthalmitis, EVS said if you have a perception of light vision, you do immediate PPV and in these patients because they will gain much better vision. So they had PL plus vision, they gave PPV, they gave tap inject. The PPV arm did well, so they recommend PL plus. So in the hand motion or better vision, they said just tap and inject. Doing PPV is not going to help them more than tap inject. Why do intervention? So this is what we see in these patients. If there is no improvement in tap inject, 48 hours, 24 hours to 48 hours is the window where we go ahead and do a PPV, definite PPV in this patient. So what happens in India in our scenarios is a work by Dr. Savitri Sharma and TP Das. LV Prasad has taken a lead in this kind of a thing. They said, why follow the EVS blindly? Because EVS has two issues. EVS had not even a single patient of a fungus in their study. They didn't have not even a very less percentage of gram-negative organism in there. We talk about streptococcus, we talk about staph, but in our population we see these pseudomonas, proteus, we see fungal on day one. So why you should not follow EVS blindly? Probably a hand motion vision and you are seeing a fungal ball there, they should be subjected to immediately paspalina vitrectomy. So early PPV is, just keep EVS in your mind, but think about that it can be a fungal, because fungal you see the vitreous cavity, you see inferiorly balls there, you see a fungal ball there, you see cornea involvement there. That means it's either fungal or a very, very devastating gram-negative pseudomonas or proteus. So you don't wait for a patient to have a PL plus vision too. Even if it's a counter finger 2 meters, 660, you do early PPV in these patients because our bugs are different from the EVS. This is very clear. Systemic antibiotics does have a role. Again, EBS said doesn't have a role because of the good systemic antibiotics and better intravitreals. They do have a role. So you have to practically load these patients with the antibiotics there. Under the cover of antibiotics, your steroids will be given, because steroids are given to basically take care of the antigenic antibiotic war is causing a lot of debris and a lot of retinal damage. So you give oral steroid in these patients. Intravitreal steroids is a controversial issue. I will not touch at that because in a patient till the time KOH is not negative, I don't think we should give, fungus is not negative, we should not give intravitreal steroids in these patients unless until proven otherwise. PPV has also changed. The EBS said do core vitrectomy. Nowadays, because the vitrectomy era is different from 1980s to 30 years down the line, we are much more safer machines. So we don't do only core vitrectomy. We do a surgery which is as much as possible debulking of the the disease vitreous is done in these patients, but we don't do hyalid removal. There are again two school of thoughts, but till the time they publish and they say that the hyalid removal is important in these patients, and I don't think the hyalid removal done in these patients. They have necrotic retina. If you try and manipulate the hyalid, if the hyalid is detached, it's all right. Then it's no point. But it is not detached. No point pulling from the disc and with the creating a suction and removing it, because you will cause iatrogenic breaks and there will be problem. And followed by intravitreal injection. The the purpose of PPV is clear the media opacity, debulk the bug, and then you declare the war with the antibiotics in these patients. And this is how normally these patients do. On the day one, they are never good, because slowly and slowly you will see this fibrin will retract. It will fall off, and gradually till the time the media is not clear, you follow these patients with the ultrasound. When the media becomes clear, if you can follow with the indirect ophthalmoscopy. The moment you start seeing the disc there, you have somehow achieved something in these patients. So to conclude my talk here, this talk is close monitoring for all postoperative patients to in these patients, because to not to have TASS and endophthalmitis. A universal approach of visual acuity, IOP, cornea, anterior chamber, and media clarity is very important. And three scenarios: always look for improvement, status quo, or worsening. And if you have a worsening there, I think early referral is the word. I've already told you about a hot potato. If you have a hot potato in your hand, a, a a diseased patient, unhappy patient in your clinic, he'll not make your life easy. So you have to pass it on to your VR colleague, pass it on to your senior guy to you, and have a peaceful sleep. Thank you so much.